So we are here for the bonus round with Dr. Mike Downey. And in the last hour, or just short of, we were talking about what I think is going to be a really free-form concept about taking some of the old school guys, including one of my professors that I had to retake a surgical course over the summer, Scott Millay, and then Dr. Mike Downey, who was another one of my professors. And they're going to be moderated by Dr. Ellen Block, a real good speaker and good vascular knowledge guy, with some of the newer docs that went through Dr. Downey's program down in Georgia, Tom Chang, Luke Ciccanelli, and there might be a third person in there. But you've set it up almost as a little bit of a tongue-in-cheek thing too. You want to get some knowledge out. You're going to certainly be going over bone grafts and things. But tell us about some of the lighter-hearted aspects of that quote great debate that you're going to do.
Well, I think we've debated for years and joked, amongst ourselves as to what's the greatest residency year ever, and I think this is our chance to settle the score. We do plan on having, like you said, Alan Block. I think he's a perfect impartial moderator. He's a brilliant guy, and he'll kind of lead the discussion and make it so neither, team kind of has an advantage, out of the blocks, and then we also plan on hopefully having the audience vote on who they thought each section. It's currently set up for an hour session on Friday the 16th and an hour session on Saturday the 17th of the meeting. So it should be very, very exciting. I mean, there's a lot of new technology that a lot of these guys are using, and different techniques that they use, and we'll criticize each other. It's a good way of being introspective and retrospective at the same time.
Yeah, those kind of discussions are great, and they happen, in the halls of meetings and at some of the dinner programs. There was a lot of talk this weekend about where's the place for capital and arm osteotomies. What's your thought? There's a lot of stuff about the Lapidus. So how do you think things fit in? What's your philosophy?
Well, it's interesting. I think everybody knows there's been a major push over maybe the last 5-10 years towards a malrotation of the first metatarsal into valgus, and that even to the point where some will say the Lapidus needs to be done for every bunion, and with that there's many different instrumented Lapidus techniques. I don't need to name them or get commercial with them right here. I don't necessarily think you need the instrumentation to perform a Lapidus. I don't use any particular instrumentation. I think the important thing, however you're doing it, is you want to get full correction, not only in the frontal plane with any valgus rotation, but you want to make sure you're not excessively shortening the first metatarsal when you resect the first metatarsal cuneiform joint. And you want to make sure your fixation doesn't result in the first ray being elevated. My take on that, there's still a very good place for capital osteotomies and shaft osteotomies of the first metatarsals for bunions. I mean, let's just look at it. I mean, for years, decades, those are the procedures that we did, and they still hold the test of time. It's not like we have tons and tons of patients walking around with failed bunionectomies from capital osteotomies and shaft osteotomies. They certainly work very well for moderate deformities. I think as you get into more severe deformities, or deformities that you can pretty easily tell have a significant hypermobility of the first metatarsal cuneiform joint, then the Lapidus has a place. But let's face it, unless you know something different, Ben, I don't know a definitive test for determining the degree of hypermobility of the first metatarsal cuneiform joint. Everybody has their sense and their feel for it, but I haven't heard anybody really come up with a reproducible and reliable way of measuring it. And the second thing is, everybody acts like the Lapidus procedure is a benign procedure. Oh, it's a joint where you're not losing much motion, and that's the critical place where the deformity arises from, and therefore it needs to be fused. There are complications with the Lapidus procedure, just like there are with any bunion procedure, and I think even the proponents of the Lapidus would tell you that. Some of these patients end up with submetatarsal 1 pain. They end up with floating hallexes. And again, if you have the problems of shortening of the first ray, you can get transfer metatarsalgia, or elevatus of the first ray, you can get transfer metatarsalgia. So the procedure needs to be done well, whichever bunion procedure you choose to do. And I think the key thing that I would say to any surgeon doing bunions today is don't try and do 10 different procedures. Try and do, 2 or 3 procedures that you kind of have mastered and that you can do reproducibly. And I think that's where the instrumentation is best. For somebody who's not doing a lot of bunion surgery and a lot of lapiduses, then I think the instrumented techniques can be beneficial, and that's where it really, I think, they fall in my mind.
Let's take it on to bone grafts. A lot of products that you can easily get commercially, and then there's also the standby femoral head, calcaneus. Where do you like to pick and choose from that smorgasbord of options? Give us some examples of why you would select one type of construct over something else.
Yeah, I think the current approaches to bone tissue engineering, they lack respect to traditional bone grafting techniques. Everybody wants to sell their product, and some of these bone substitutes or orthobiologic materials are extremely expensive, and oftentimes I find that the more expensive ones are overused. And everybody's heard the terms osteogenesis and osteoinductive and osteoconductive, but I think when you're looking at what you're trying to accomplish with bone graft, you need to look at what you need. If all you need is structure, that's osteoconductive. You just need the scaffolding. That's probably the cheapest of the alternatives. That's an allogeneic bone graft in a bottle, or that can even be calcium sulfate or calcium phosphate derivatives, which are, the cheapest. Calcium sulfate's plaster of Paris. I mean, it's the cheapest of everything. And then, if you need something that's osteoinductive, that's where you're trying to turn on the cells. You're trying to turn the cells into, osteocytes and into osteoblastic activity. And that can be done with DPM and different things, or even that's what your bone stimulators do. They try and turn the cells on to become more osteogenic in nature. And then the best of all is the cells that are osteogenic. Those are actually the living cells, and that's what's in an autogenous bone graft. And obviously, the cancellous bone is more osteogenic than cortical bone. But I said at the recent seminar, and I've said many times in the past, I think we underutilize the patient's own bone when we're doing these complex hindfoot surgeries. One of the things I like to do is harvest the bone when I'm resecting joints, when I'm taking bone wedges out and everything out of the patient. And then I morselize it. I put it into a bone mill or a bone grinder, and I pulverize it, make a paste out of it. And if it's primarily cortical, then I go up into the patient's tibia and I do a bone draw out of the medullary canal, get stem cells out of the medullary canal, the proximal tibia, and I mix that in with that slurry. So I'm using the patient's own stem cells, I'm using their own slurry of their cortical cancellous bone. I'm getting osteogenesis, I'm getting osteoinduction, and if I have the good structure, there's not much more I need. And I save the patient and the insurance hundreds and hundreds of dollars from unnecessary use of some of these very expensive orthobiologic materials. I'm not saying there's not a place for them, but I think we really need to critically look at it, not just take, hey, a rep's in the room providing you with screws or plates for a case. So let's use some of their orthobiologic materials for here today. I get away from that mentality.
Now I'm going to talk about a broader thing that colleagues have brought up, certainly our patients have brought up, and I don't know what the atmosphere in the Philadelphia, Jersey sort of tri-state area up where you is, but we have a lot of a particular commercial store that's available where you can get orthotics that are made at the store. There are not doctors there. And it is also a place where you can get better footwear options like Rockports, Sam Hubbard, Mephistos, etc. I sort of call it the retailization of podiatry. On the one hand, you have these great graphics, they'll be right after the Today Show, where they had just had some foot guru that is really a glorified ex-yoga instructor or something like that, talking about the best shoes to get your foot, and they'll segue right into one of these commercials, and then your senior patient watching Al Roker do the weather, they'll come in and they say, I've already got a round of orthotics that cost me X amount of money, and they're usually very expensive for these sort of pre-staging orthotics, etc. Give me your sort of overall take. Now you're talking to both doctors and the lay public, because I'm sure if I tag the name of one particular place in general, people maybe spark their interest. What's your thought, though? You've been doing this a long time. What do you think?
Well, first of all, it's competition. I mean, quite frankly, that's what it is. And if you want to win the competition, you got to offer a superior product. And it's that simple. In any discipline, anything, the public is going to want quality, and the public is going to want, reproducible quality. I happen to think a good neutral position cast, suspension cast technique for orthotics or some type of 3D computerized technique is the best way of accomplishing an orthotic today. And I think you get what you pay for a lot of times. I just had a patient, went to a local pedorthist facility, and they had the patient stand in foam boxes and made the orthotics out of the foam impressions. And the patient comes back in and brings the orthotics and said, I got the orthotics, like you said, doc, and they don't seem to be helping. And I could put both my fingers between the top of the orthotic and the bottom of the patient's arch. I mean, it's just amazingly poor. But I don't think this competition is going away. I think I remember the one we can all talk about. It won't go to the one I think you're referring to, but is the Dr. Scholl's, where you go in and you step on the device right in the Walmart. And I remember a patient one time with severe flat feet said, I went in and I stood on the machine and I put 1 foot on at a time, and it kept telling me 1 foot at a time. And I only had 1 foot on there, but my foot was so flat, it couldn't recognize it as just 1 foot. And, how can that possibly compare in the quality to what can be done by a competent sports medicine physician or podiatrist, or somebody that's expert in making a custom molded orthotic? But I think it's all about, we need to educate the public. We need to show why our products are superior. And, that's going to be done, through different sports medicine organizations. It's going to be done in our publications. And it's going to be reaching the lay public's publications, Running World, other magazines that, sports medicine oriented, and educating them as to, where the best orthotics are made. I think there's no comparison to a well-made orthotic by a competent sports medicine person than going to any of these stores where, you got the kid right out of high school working after hours in the place and has some limited knowledge. I'm not going to say they have no knowledge, but they have far less knowledge in the training that the average podiatrist or average competent sports medicine specialist goes to.
Yep.
So,
I think the other part of the PSA with this is that it's kind of like the old, elephant looking at the trunk, but not seeing the whole elephant. They could well have a limb length discrepancy. They could well have some kind of osteochondrosis. They could well have, and very rarely, but we've seen them, they could have some kind of tumor. It's not always plantar fasciitis. So, we also have to appreciate the old saying about when you're looking in the barn, you're looking for horses, not zebras, but sometimes the zebras do show up. So I think there's that part of the equation as well.
absolutely.
All right, well, listen, I want to end it on this. I always like to ask a couple questions related to, what you do to recreate, to kind of find your work balance. And I think that's an important one. We've been in, the last 3 days have been upside down. I think I kind of liken it to sort of cat dog ears. I find a time compression sometimes with the last 3 years trying to look at things. How have you found work-life balance, and whether it be walking and meditation? What kinds of things are you doing to sort of soldier on through, and luckily things have gotten better. We've got some great vaccinations. But what's been your kind of genesis with this?
Well, I do think you need to have an outlet outside of, whatever your specialty is, whether it's podiatry, surgery, whatever it might be. For me, over the years, I've been a very serious chess player. I constantly battle to try and make master level in chess, but just to show you, anybody who wants to get good in chess, if you look at the highest levels, Magnus Carlsen is current world champion in chess, and the guy is an avid tennis player. And you have to have an athletic outlet even for chess to perform at the highest levels. And if anybody's watched the Queen's Gambit, you've gotten a sense of the intensity and the level that these chess players get to. But I enjoy playing chess. I enjoy hiking. I enjoy golfing. I mean, I constantly when I have free time and making that available. I think the millennial generation, for all we make fun of and joke about it over the years, one thing they have right is I think they struck a better work, outside of work, recreation balance than the old guys like myself. I mean, I think, my era, we worked, and then we worked some more. And, I think as I get older, I realize that work, recreation, outside work balance, your family, your friends, those are the key things. And, even in podiatry, I look at it that way. I mean, I don't need to give another lecture to anybody. I've done it. I've been there. I've written books. I've lectured all over the world. I do it because I like my colleagues. I like seeing the Ben Pearls. I like seeing my colleagues in the community wherever I'm going. And that's really what revives me. I like socializing with them. I like talking about cases, sure, but I like talking about their families and what they do outside of work as well. So I think it's that work-fun balance that we all have to strive to get better at.
Well, that is great that you're finding something like that with chess, and it's something that I do with my son. Once we'll play a live board game, but when he goes to college, that's another way. With this postcard chess and the masters things that you're talking about, that you can continue that. Well, just as a reminder, and continuing that sort of social didactic discourse, remind everybody, if they want to come up to Philly and have some after hours chats with you and the rest of the faculty, give us the lowdown on when that's going to be.
Yeah, so again, it's going to be a great faculty. I just mentioned that, 4 or 5 of us, but there's about 20 different faculty, all through Penn Presbyterian, the Podiatry Institute. We got Andy Meyer from the Temple School. We got Kieran Mann coming, Tracy Belhovic, many, many others, Spencer Monaco, Mike Triano, a lot of great guys that can, provide good camaraderie. It's
That second week of September, right?
September 16, 17, and 18 in Philadelphia. You want to sign up for it, just go to the Podiatry Institute website, www.podiatryinstitute.com, and you'll see the Philadelphia seminar on there. You can see the brochure. You can register for it. It's at the DoubleTree Hotel in Center City, Philadelphia, a very beautiful area, and right across from the Academy of Music. And really, it's the theater district of Philadelphia. A lot of fine restaurants. It's a great weekend for everyone.
Well, Mike, Dr. Downey, thanks so much for doing this. And I will be sure to be attending at least one of those days myself, and look forward to seeing you again in person. And I really thoroughly enjoyed this chat tonight. It was fantastic.
Thanks, Ben. I enjoyed it too, and I appreciate you inviting me. And everybody who's listening, thank you very much for your time and your attention. Take care.